Welcome to the ICU Podcast, where we explore the vestibular experience through conversations between patients and the health professionals who care for them.
During this podcast, we invite patients to share their stories and healthcare professionals to ask questions so they are equipped to better care for and truly see the invisible challenges faced by their patients. I'm Kimberly Warner.
And I'm Cynthia Ryan, and we are your hosts on this journey of discovery. Hello and welcome to this episode of the ICU Podcast, where we shine a spotlight on the often overlooked world of vestibular migraine, a condition that affects more than half of all migraine sufferers at some point, yet remains frequently misdiagnosed. Vestibular migraine not only causes headaches, but also vertigo, dizziness, imbalance, and sensory sensitivities, making it a formidable challenge for both patients and clinicians. Today, we're joined by two remarkable guests, a dedicated volunteer with the World Migraine Summit, which, by the way, takes place March 11th through the 18th of 2026. And she brings lived experience and advocacy insight to this important conversation. And Dr. Brian Ward, a neurotologist at Johns Hopkins Medicine. Together, we'll explore how lifestyle management, medication, and other targeted therapies help restore balance and hope to those navigating vestibular migraine. So welcome. I'm going to start by introducing Dr. Ward. Dr. Brian Ward is a neurotologist with Johns Hopkins University who specializes in treating inner ear and skull-based disorders that cause dizziness, such as superior canal dehiscence syndrome, Meniere's disease, bilateral vestibulopathy, vestibular migraine, and more. His research interests focus on magnetic resonance imaging and interactions between strong magnetic fields and the inner ear, which sounds really fascinating to me. He also works with Dr. Charles Della Santina on the development of a vestibular implant. Welcome, Dr. Ward.
Thanks so much for having me.
We also have Natanya Mandel with us. Welcome, Natanya. She is a migraine coach, a mindfulness facilitator, and passionate patient advocate whose own journey with frequent migraine attacks and disruptive neurological symptoms inspired her to shift her career and support others living with migraine and chronic pain. Natanya has volunteered with groups like Migraine Canada and the Migraine World Summit, facilitates virtual support groups, and helps people navigate the challenges of chronic migraine with compassion and evidence-informed guidance. Thank you, Natanya, for all that you do. Can you start a little bit by sharing your personal journey and your personal journey with vestibular migraine specifically, and what your symptoms were like, how long it took to finally get a diagnosis, and what that whole journey was like for you?
Yeah, thanks. Thank you for having me. It's great to be here. Vestibular migraine, I guess, felt like it happened very suddenly for me. One day I just got dizzy, and I was dizzy 24/7, or vertigo, I guess, where the world's spinning, for a couple of years. And I'd always had migraine with aura, but I was diagnosed at a very young age. But the dizzy was very sudden. And in the process of learning about it, I realized that actually I'd had symptoms of vestibular migraine, what typically goes with vestibular migraine, my whole life, but I didn't know that they were unusual things to be experiencing. But the actual dizziness just was very sudden. I think I was actually pretty lucky with the whole diagnosis process because I was in Sydney at the time, Sydney, Australia, and I was already being treated for migraine. And so I was referred to, I actually was admitted to hospital with my dizziness and kept overnight by the neurologist. And then I was referred to what was then called at the time the Dizzy Clinic at Royal Prince Alfred Hospital, and which was pretty close to my home. And anyway, and they did lots of space age testing, some of which was very unpleasant. Actually, awesomely for me, that one of the things they did was looking at my brain waves, and they could see that the dizzy happening, or they could see activity happening as it was happening. I can't remember exactly. It was a long time ago. And my husband was in the room, and he's like, "Oh, what's that?" And so they were able to say, "Oh, that's XYZ." And so it really cemented for him exactly that it was happening in my head, really, not just in my head, imaginary. So he was always very supportive, but it really helped cement for him and for me that this was a real experience, a real condition. I think, I have some interesting anecdotes as well in terms of the diagnosis. So in the lead up to the diagnosis, at the time I was the executive director of a nonprofit, and the chair of my board came and picked me up from home and took me out for lunch, and we were talking and having a nice lunch, and then I just suddenly fell off my chair like a drunk person. Just all of a sudden my chair gave out from under me, and so she laughed hysterically. She thought it was hilarious, but at the same time she took me straight home, took away my laptop, and told me I had to rest. So, it was just really nice to be recognized. It wasn't nice to be, dizzy in front of the chair of my board. I was very embarrassed, but it was nice that she kind of grounded it, like made it seem not as like, there was no blame, I guess. So, it was really nice to have that understanding and that groundedness. Not so nice to be laughed at, but I can understand why she thought it was funny, because it's pretty funny falling off your chair for no reason. So that was in the lead up to the diagnosis, and help. Then I was lucky because I had the support of my workplace to chase down a diagnosis, to get all the help I need, to take all the rest I needed. So that was really a clarifying process for me.
That's really interesting to hear, that you had migraine, and then the vestibular migraine came on really quickly, and you were so fortunate to be near a university hospital with a dizziness center. Thank goodness for that. So we know that vestibular migraine is one of the most common causes of dizziness, and yet it's still under-recognized and probably underdiagnosed. Dr. Ward, how prevalent is vestibular migraine, and why do you think it's so often overlooked or misdiagnosed?
Yeah, vestibular migraine is a highly prevalent condition. It's estimated that between 1% and 3% of all adults will experience vestibular migraine in their lifetime. And if you look at patients who have a history of classic migraines, between half and 2/3 of them will have vestibular symptoms that are attributable to their migraine. So it's an incredibly common disorder or diagnosis, but it tends to be significantly under-recognized. And I think there are probably a bunch of different reasons for that. One is because we still tend to think of migraine as a headache disorder. And so a lot of practitioners will assume that if you don't have a headache, you can't have vestibular migraine. But that's not necessarily true. A lot of people will have dizziness symptoms without having classic migraine symptoms during their attacks. So I think that's part of the challenge, is one of education. I think the other challenge is that it is a syndrome, and so there are no blood tests or imaging studies that can say that you have vestibular migraine. And if I think people recognized a little bit more the diagnosis, I think it would be more commonly diagnosed, and I think that's happening.
So, yeah, vestibular migraine is so common. It feels like everyone that we've met, Cynthia, through all the work that we've done, it seems like it's almost accompanies all the other vestibular disorders. And I'm not going to say 100%, but it just feels like it's just a very prevalent, and it's a bummer that it's not diagnosed as quickly as it should be. That said, once we are diagnosed, there are strategies. and things that we can do. And I'm curious, Natanya, what you found, because I think it's different for everybody, from diet to pacing to medication. What have you found that's been the most helpful for you?
Yeah, for me, I would say pacing and medication, a combination of those two things, have been most helpful. I haven't found any particular foods that impact me or don't impact me. That's just my personal experience. I know other people experience differently, but that's been my experience. So it hasn't been about one magic fix. It's been about layering supports. So medication obviously played an important role. Looking after my nervous system, I actually stopped working as much and is in as stressful roles as well. So, my career shift, though that wasn't the reason for my career shift, that actually made a huge difference to how often I have, say, dizzy spells or whatever. And learning to respect my sensory limits. So I think, one thing that made a really big difference for me, which took a number of years for me to fully realize, was it was actually during the testing process at RPA. And he said to me that my brain was working 3 times as hard trying to process all the information that was coming in. So, because I complained that I was tired. And so, just to be kind to myself, to recognize that's exhausting when your brain is trying to understand everything, time, space, all the information that's coming in such an unusual way. And that it wasn't and so for me, it wasn't about, it was about recognizing that it wasn't a personal failing. It was that I have a neurological condition that's impacting, how I am in the world, and that rest isn't a weakness. So, it's a strength actually, and a way of looking after myself and then contributing more. So in a way that's safer for my body. And so, that understanding really took a long time to fully embody, but for me, pacing and medication was the way I managed to bring it under some kind of control.
Yeah, it is really hard to separate who you are from your migraine symptoms and not feel like it's a part of you that not that they're your fault, but that you're, you can't do these things for some reason that has to do with the effort you're putting into them. I know I'm watching my husband go through this right now. He's in the process of being diagnosed with something vestibular, and we're not even there yet. But when you said about vestibular testing, Natanya, pleasant that was. When he went off to go get his vestibular test, I said, do you want me to come with you? He's like, oh, no, I'll be fine. And then he walked in the door afterwards, and I'm like, he said, oh, that was unpleasant.
Oh, Cynthia, what a strange twist of events for your husband or your partner to have this that you're dealing with. I mean, you have so much information and resources to offer him. So hopefully he's And yet it took this long. I mean, he's been suffering for 7 years with undiagnosed symptoms. But that's the thing is there are lots of confusing symptoms, and he has other things going on that are not vestibular, and so that got kind of mixed up with the vestibular. And now they've ruled out, the tests ruled out an inner ear disorder and have said that it's central. So here's my question for you, Dr. Ward, is how do you tell the difference between vestibular migraine and other neurological disorders?
Yeah, and I think what you're describing, and Natanya as well, is just how long it can take to get a diagnosis of vestibular migraine. The diagnosis is relatively straightforward. It's what we call a clinical syndrome, so that you have to have so many of one symptom and two symptoms. And if you have all of them, then you kind of meet these criteria for vestibular migraine. And so that's an established diagnosis that the Bharani Society has published. But you have to have a present or history of migraine, as in Natanya. So a lot of patients, for instance, will have had classic migraines in their kind of teens and 20s, and then they may say, well, they went away. My migraines are gone. And then later on in life, they start developing new symptoms, which can involve sort of more subtle head pressure, dizziness symptoms. And that's often when they start to come in with symptoms of vestibular migraine. So you have to have a history of migraine. You have to have, over time, a number of attacks of episodes of vertigo or dizziness. And I think the other thing that gets a little confusing is that, we spend as clinicians a lot of time distinguishing between, are you feeling a spinning vertigo, or is it more of a lightheadedness? But in migraine, the symptoms can be much more vague than that. They can feel like the world is sort of tilting, or you're walking on clouds or pillows, or if you turn your head, it takes a second for the world to catch up. And they don't quite fit into that classic thing that a lot of clinicians are looking for is, are you feeling like you're rotating in a circle? And that's not always the case in vestibular migraine. I think, in fact, most of the times it's not. So you have to have a history of headaches, a number of vertigo or dizziness episodes, and then often a sensory sensitivity, which is really common in migraine. So people will experience light or sound sensitivity, sensitivity to self or visual motion, especially around the time of episodes. And then I think what is often the case is that patients have normal or near normal vestibular testing. So when they go in and they get their balance testing, their inner ear function tends to be normal. And I think that can sometimes be disheartening to people, is that, well, they're looking for something to say that, well, I feel so bad. Why can't you identify the location of the problem with your tests? And I think that's, sometimes it's reassuring them that this is good news. Your inner ear is functioning great. And it's just a problem of integrating information. And then in terms of differentiating from other disorders, I think it was mentioned earlier, Cynthia or Kimberly, that there's a lot of overlap between dizziness and balance disorders and vestibular migraine. And we tend to think of a lot of these as being effective migraine triggers. So for instance, in another disorder called Meniere's disease, up to half of people with Meniere's disease, which is an inner ear disorder, start getting vestibular migraine symptoms at some point. And it's important to differentiate those because there's very different treatments depending on which condition you have.
Boy, I wish that more of the neurologists and the nurses, the practitioners that are delivering those vestibular tests didn't deliver the great results with such enthusiasm. I think so many of us, that were more on the central vestibular disorder side, went through those as if they were going to be a lifeline and an answer to all of our misery. And when it's handed to us with a big smile and a pat on the back, it's just so disheartening. So there's a lot we can do. I'm sure, Brian, you don't do that. And I'm sure that, you're probably doing a lot to help those other doctors understand the challenge of just even getting the diagnosis in the first place.
Yeah. I mean, that's exactly what my husband was dealing with, is his tests came back normal. So what does that mean? And I know we've had all conversations with audiologists about this, how you share that, okay, these tests are normal, but that means that we need to do this next.
Mm-hmm. Yeah. Natanya, I think we're kind of hinting at this, but invisible illness can be really isolating and even devastating. So how have you navigated this with outside of the clinical setting? When you get home, what do you tell your friends and your family or even your employers about what you're going through?
Yeah, I have to say it's been, I think that the dizziness is a very particular type of invisible illness. Early on, my sister-in-law actually asked me what's worse, the pain from migraine or the dizziness, and I said to her, the dizzy, and she, which is how I refer to it, just the dizzy. And she just didn't even believe me. And I say this not being critical, but of her, or there's no criticalness, but what it brought home to me was that pain is relatable. People understand pain. They've all experienced pain. People have had surgeries, people have fallen over and hurt their knee, whatever. You bang your head sometimes. Like people, and most people will have a headache at some point in their life. Not everyone, but most. So I think what is difficult about vestibular migraine and being dizzy or lacking balance is it's very difficult for people to imagine that, to relate to it. And so, it's taught me to use the words that were used with me by the people testing me to explain what it's like, to explain, well, this is actually what it means. Like when I walk, this happens. And to try and give people more of a thorough understanding of what the experience actually is. So I'll say things like, and I try and ground it. So I'll say things like, well, I can't sit up, I can't lie down, I can't walk downstairs, but I also can't walk upstairs. So, they start thinking, oh, wow, that's really impacting you on every level. And so I just try and make it really relatable for people about what the lived experience is, rather than trying to explain the neurological background, which I'm not qualified. If they asked any questions, I wouldn't be able to answer them. So, yeah, so I find that helps, but it is hard for people to relate to the dizzy, and that's really isolating when you're having an episode. That lack of trust in your body, that it can just suddenly not work how it's supposed to be. That's very, that sense of balance and safety just suddenly going can be really disorienting and difficult to manage.
Yeah,
and
you described that so well.
Oh, thank you. Yeah. Well, one example is like one time I went to a show with my 20-year-old, and there were strobe lights in this. It was it wasn't a Broadway show, but it was Toronto's version of Broadway, which was Mirvish Theatre. And there were strobe lights, and it triggered a massive dizzy attack for me. And then I walked out, and it was a circular staircase, and down the circular staircase there was a banner which was swaying. Oh. And the crowd leaving of hundreds of people all trying to exit. It was just, and she told me I looked like a drunk person, which of course I probably did, falling all over the place. And so we sat and we waited. She made me sit. I wanted to keep walking because I wanted to escape, but she made me sit and wait till the crowd dispersed. And but here's this kid, she's very young looking, with an apparently drunk mum at the show, and I could feel people looking at me. Like, it was very difficult.
Yeah.
If we could only create something that simulated what it feels like to be in that moment of where your senses are just overwhelmed, so that people could viscerally understand what vestibular patients experience, that would be our key to increasing awareness, I think.
And we also need another word for pain, because even how many forms have you filled out, Natanya, where it says on a scale of 1 to 10, what is your pain? And you're like, I'm not in pain. But
yes, that's not my most troublesome symptom.
Yeah, it's like, but if you ask me my distress level, it's a 10. So it's like, I think we also need to really sort of widen our definition of pain, that right now it just doesn't include dizziness.
Yeah. Well, I think that when asking about migraine, I think that in the testing, in the HIT6, those questionnaires, only asking about the headache is very limiting, because there's a lot of people that's not their most troublesome symptom. They get headache, but they can keep going, whatever. It's the other things that might be more troublesome, like dizzy, for example, which are really important for the clinician to know. It might change treatment options, might change where they refer you to.
Right. Dr. Ward, when you finally arrived at a vestibular migraine diagnosis with a patient, I'm guessing the first step is medication. So I kind of have a two-pronged question for you. How do you find out what medication to use for any particular patient, and then what else do you do to help coach them through all these other things that Natanya is talking about?
Yeah, well, when I see a patient and suspect that they have vestibular migraine, I think the first and most important thing is sort of giving them background on the condition, like how prevalent it is, what kind of symptoms that they're going to experience, and how it's related to migraine and why migraine can cause symptoms other than just headaches. So I spent a lot of time just kind of just explaining what we understand about the pathophysiology of migraine. And the way that I tend to do it is that I start by describing what we call a threshold, so that everybody has a certain threshold to get migraine, and anybody could get a migraine at some point in their life. And what you acquire is certain triggers. And so in migraine, there are certain well-known triggers, things like poor sleep or stress or hormone fluctuations. There are a lot of dietary triggers, foods that we would often consider as health foods, things like avocados and citrus fruit and bananas, and they can become migraine triggers for people. So actually, before I even get to medications, I start with a lot of lifestyle modification, discussing about kind of sleep habits, dietary trigger regulation, and then the next step would be dietary supplements. So there are some supplements like riboflavin, coenzyme Q10, and magnesium, which actually have quite good evidence for migraine prevention. And the way that I think of them and the medications is that they just make your threshold higher. So, you try to eliminate any triggers you can, or you make your threshold higher, or both. And both of those in combination makes it less likely for you to get migraine symptoms. I often will talk about our goal is to kind of have no more than about 2 headache or dizziness days in a month. And most patients that I see will have, oh my gosh, I have 4 or 5 a week. And so, there's a lot of room to improve. So that's first, is that dietary changes, supplements. We do that for about 8 to 10 weeks. And then that's when I say, if you're still not better at that point, that's when we think about starting a daily migraine preventive agent. And the way that I counsel patients is that we always start, and this is true for a lot of patients with migraine, they tend to be very sensitive to small changes in medicines. So you always have to start at a very, very low dose and just kind of gradually escalate. And then in terms of the choice of the medicine, that depends a little bit about other kind of medical conditions that the person might have. A common one in my practice is to focus on some of the anti-anxiety, antidepressant agents, things like nortriptyline or venlafaxine. And I do that because a lot of patients with dizziness symptoms have high levels of anxiety. And I kind of think of it as they go hand in hand. The anxiety can increase the dizziness symptoms, and the dizziness can increase the anxiety. So they tend to work well as first-line agents for me.
I've been on the venlafaxine for, I think, 4 years now. And the way I describe it is, I feel like there's a Nerf ball around my head now. So I have sort of this protective barrier between the sensory input and my personal reaction to it. And I'm on I keep lowering the dose, but even when I started, I was at like the pill that doesn't even exist to the ENTs. I remember requesting it because Dr. Bay prescribed the 25 milligram immediate release. And my ENT said, that doesn't exist. It only starts at 38. And I was like, no, I'm pretty sure there's another one. And she said, no, you're wrong. And it was, I eventually had to go back to my neurologist to get the one that he prescribed. But it's even amazing that the ENTs and the neurologists don't agree on some of this information. But it's been very helpful. So what else has been helpful for you, Natanya? I know that there are a lot of resources out there and support groups and podcasts. What have you used?
Yeah. So obviously, actually, in Australia, I used nothing. And then when I got to Canada about 8 years ago, I guess, I started actually researching a bit more. And so since then, obviously I discovered Vita and the resources that you have, which has been incredible. And I started reading books on vestibular migraine. So, through my work with Migraine World Summit, I learned about Dr. Shinbei and other specialists that work, that have really worked hard on vestibular issues and vestibular migraine. And so reading some of those books and resources, listening to those interviews, listening to various podcasts as well, has been really helpful. And for me, I think I would say that one of the most helpful thing was learning about all the different symptoms that I didn't know were symptoms, because I'd been experiencing them my whole life. Things like, looking at something and then looking away, but I can still see the imprint of it. Alice in Wonderland syndrome, which I thought was completely normal, like just life. There's nothing weird about that. And then reading, oh, this is a symptom, a few other things like that. It was like, oh, and for me, it just made it feel really grounding and validating. Like, oh, I didn't know. And I turned to, a member of my family and I'd say, oh, do you experience this? They'd be like, what? No. And so I'd suddenly think, oh, I wonder what else is going on that has always happened that I didn't know other people didn't experience. And even things like sometimes I see things through what seems like a glass wall. So learning about all these things through all the interviews, like podcasts like this one, interviews on Migraine World Summit and books, have really helped, make me realize, oh, that's actually like a little mini episode or a little mini experience or whatever it is. So I'm able to, really just take care of myself from that point, so that, oh, okay, if I, back when I would have just ignored that and then may have ended up being unwell. So now I'm going to, do something to look after myself and calm my body down.
Yeah, I think we're really fortunate to have so many resources in the vestibular community, both from the perspective of patients sharing their stories through podcasts. And I'm going to use this opportunity to give a shout out to Alicia Wolf, the Dizzy Cook, and all the work that she's done raising awareness about diet and its impact on vestibular migraine and other vestibular disorders, as well as supplements like we all already talked about, as well as the World Migraine Summit, which brings in just these amazing experts in migraine, vestibular migraine, and other types of migraine. But on the one hand, I think, and when you were describing, listening to what someone else is describing helps to identify that within your experience. And yet there are so many different experiences. Everyone is different. And I'm curious, Dr. Ward, does each person's different experience of vestibular migraine, what is that, what does that depend on? Does it vary based on things like age, medical history, comorbidities? How do you counsel patients when every one of them is different?
Yeah, that's a good question. I think of it as just, I was thinking about the neurologist and writer Oliver Sacks, who has migraine, and he would experience these really kind of unusual visual symptoms and sometimes auditory symptoms throughout his life. And actually, that was the motivation for him to become a neurologist and to write about these fascinating things that happen in the brain. And I think of it as it's kind of like electrical storms that are happening in different parts of the brain, and they cause a variety of different symptoms. But I'm not sure that the treatment or how we address it is that different depending on how somebody's symptoms present, at least in terms of vestibular symptoms. The one caveat to that would be that a lot of patients have other disorders, as we talked about, and you have to carefully tease apart those disorders because they have different treatments. So patients with vestibular migraine are much more likely to get BPPV as well. And I think we have to be cautious not to assume that any new symptom that somebody might experience with vestibular migraine is just another new manifestation of their vestibular migraine, because if they have BPPV as well, then they need canalith repositioning maneuvers that we can do in the clinic or that physical therapists can do. And that part of their symptoms can be controlled with a different kind of intervention. So I think if symptoms are similar over time, then we just kind of treat them as their vestibular migraine symptoms. And we do tailor medicines and choices of medicines depending on somebody's age and other medical comorbidities. But I think less in terms of how they describe their symptoms. I think that's still pretty similarly in how we treat that.
Could I actually want to piggyback on that because you led into it so perfectly. Triple PD is now we're learning is very commonly overlaps with other vestibular disorders. So how important is it to have a multidisciplinary team to deal with each of those? If someone has triple PDN vestibular migraine or triple PDN BPPV, what does that look like in treating them?
Yeah, a multidisciplinary team is essential for vestibular migraine and with triple PD. And as you mentioned, this triple PD or persistent postural perceptual dizziness is a syndrome that we've known about in vestibular science for decades, but I think it's only been within the last about 15 to 20 years that we all kind of got together internationally and decided, hey, we're all talking about kind of the same thing here. And we're all seeing the same kinds of patients. And so that's where it feels like a new diagnosis, this triple PD, but it's been known about for a long time. But the nice thing about that is that once everybody starts to agree on a term and a diagnostic criteria, then we can do better about studying it and figuring out how it relates to other disorders. And so one of the things that we've learned is that so many different vestibular conditions can lead to a triple PD. And what is triple PD? It's sort of like the brain is on high alert to all self and visual stimuli. So patients will feel some sense of disequilibrium or dizziness on a daily basis for many months, very sensitive to visual motion, and then the more active they are, the more dizzy they feel. But the symptoms are not episodic, they're daily and persistent, but different intensity. And so vestibular migraine is just one of the disorders that can lead to triple PD. And then once somebody has a diagnosis of triple PD, then it's a combination of interventions from multiple different providers. So you're likely to need some sort of medication, something like venlafaxine or an SSRI. You're likely to need to work with a vestibular physical therapist to expose yourself to all these stimuli, visual and self, that you really don't want to expose yourself to because it makes you feel worse. And that's where I think where cognitive behavioral therapy also becomes really important for triple PD, is because it can be really difficult to motivate yourself to move when everything you do makes you feel worse. And it is the thing that you most need to do in order to kind of get through this cycle. And I think sometimes seeing a therapist who specializes in cognitive behavioral therapy can be a really helpful adjunct to those other treatments.
Yeah, for sure.
Natanya, I'm curious about advocacy. It seems like you light up a little bit when you share, and you're very articulate, and you've thought through a lot of this process as you're living through it. What has that been like for you to share your story and connect with others?
It's surprisingly healing to share your story and to use it in a way that benefits others. So not making myself the center of the story, I guess. I'm just a player in it. And, I think it's, whether you're falling off a chair at lunchtime or, looking like a drunk person with your child, these moments help other people see more, and they help people who have similar conditions feel more seen, more recognized. And so for me, it's really given me, advocacy has given me language, it's given me agency. It's allowed me to, I've always worked in the nonprofit sector. In Australia, I worked in the homeless, mental health, all those sorts of services. And so now it's given me a way of helping my own community, people who are experiencing similar to me, in a way that also gives back to me, because I learn as I go, and I learn from everybody that I talk to, and it's really empowering.
Okay, Natanya, you've mentioned, and we've talked a couple times about the World Migraine Summit. Do you want to share a little bit about that? And also, do they have vestibular migraine as a topic this year?
They do. They have Yonit Arthur, the study coach, being interviewed this year, and what's the title is a whole person approach to overcoming dizzy and vertigo. So they do have a talk on vestibular migraine again this year. Last year they had, I think, Dr. Shinbei from memory, and so they do. It's one of the most requested topics at the Migraine World Summit. I think so many people experience different dizzy, different dizzy diagnoses type issues, and also it's just, being dizzy is a symptom of migraine anyway for a lot of people. So people really want to learn about how to manage it. What does it look like? What are the different types? How can I approach it? I really appreciate you recognizing the Dizzy Cook, because she's really been amazing in terms of advocacy and knowledge, and even just learning about different types of magnesium from her, and like all those types of things, just really helpful grounding things. And I think this is what people are after. So we've got a really great talk this year at the Migraine World Summit.
Fabulous. And what's great is VITA's virtual conference is the week before the World Migraine Summit. So Life for Balance Live, which is VITA's virtual conference, is March 2nd through the 6th. And we do have one topic that is on the comorbidities of vestibular migraine and triple PD. And our speakers are Dr. Shinbei, which anyone who's in the vestibular migraine community knows, as well as Dr. Kristen Steenerson, a neurotologist with Stanford University. And Alicia Wolf is going to be one of our patient panelists that week. I think she's actually talking on another topic that's about research and innovation. So I encourage everyone to go check that out. We'll include the links to both of those in the descriptions of today's podcast. And I want to thank both of you, Dr. Ward and Natanya, for sharing your expertise and your personal experience with vestibular migraine with us. I think this is one of the great things about the vestibular community, as we've talked about, is bringing the expertise of the medical community as well as the lived experience of the patients forward, so people can understand what's going on with them and feel validated in their experience. So thank you so much.
Thank you both. This is a wonderful conversation.
Thank you.
Yeah, thanks so much. Really appreciate that.
Thank you. Thank you for having me. Yeah.
Thanks for tuning in to ICU this month.
We hope this conversation sparked new understanding of the vestibular journey. And for all of our patients out there, leaves you feeling just a little more heard and a little more seen. I see you.